Hello everyone, let's talk about nephrectomy anatomy and pathophysiology. We're going to see if this gives you a better understanding of the anatomy surrounding a nephrectomy. So, things about the kidney we need to talk about. First thing is that the kidney has this pyramidal, what looks like fatty tissue up here. This is actually the adrenal gland. So we're going to want to make sure that when we are taking out the nephrectomy that we are leaving the adrenal glands behind, and they sit directly on top of each kidney. The kidney and the adrenal gland are covered by a piece of connective tissue that is very thin and shiny, and it's called Gerodi's fascia. And when we remove the kidney, we try to leave Gerodi's fascia over the top of the adrenal gland, because that's really what's holding the adrenal gland in place, as well as the kidney. So we try to leave that connective tissue there so that the adrenal gland stays where it's supposed to be. This picture doesn't show it, but there are fatty parts around the kidney. When we take those out, if we can, if the surgeon has dissected them, we want to leave those fat pads in some wrapped telfa with some saline, just because we may need to pad this adrenal gland after we remove the kidney if we are doing a total nephrectomy. Important things to also notice on the kidney. There is a renal artery back here, renal artery here. If we see where they are coming off of, they are coming directly off the aorta. There is not a ton of room between these two structures. So just know that we are very close to some giant vessels. Also, these themselves are giant vessels. So we want to make sure that we're extra careful, that we do that meticulous dissection so that we know what we're clamping, and that we make sure that we get all branches clamped of this pedicle to make sure that we don't have any bleeding. Renal vein drains the kidney right into the inferior vena cava. So once again, giant vessels. However, the vena cava tends to want to collapse on itself. So it kind of flattens out. It does this thing where it kind of flattens out over itself, and the aorta kind of comes on top of it. So we want to make sure that when we are looking at these structures that we identify the inferior vena cava, know where it's at, know where our structures enter into the inferior vena cava. There is a nerve that runs right along here, and that is the renal nerve. It doesn't get shown a lot on pictures, but it is part of the anatomy right here. The renal artery, vein, and nerve all together are called the pedicle of the kidney. So this whole complex right here is the pedicle. As you can see, the ureter is coming down and into the bladder. The ureter runs retroperitoneal, so it dives against the abdominal wall and is covered up by the fascia of the peritoneum. So it is outside of the peritoneal cavity as it runs along the abdominal wall, dives back into the peritoneum down here next to the round ligament and into the bladder. All right, there's our general overview. Now let's talk about the parenchyma of the kidney. Parenchyma means inside, the functional portion of the kidney. The kidney has several different areas that you need to be aware of. These pyramidal structures are called the renal medullas. So there are renal medullas all over the place. They also have a renal cortex around the outside of the medullas. So remember that our nephrons come in from the renal medullas through the cortex back into the medullas and then drain into the ureter, which is drained into these calyces. These are minor calyces up here, major calyces here, And this is a renal pelvis, where these major calyces all meet, is called a renal pelvis. A renal column is the spots in between the medullas. And then obviously we have a capsule around the outside of the kidney to hold it all together. And then Garota's fascia lays right on top of that kidney. So this is the inside of the kidney, what it looks like. Most of our stones get stuck in these major or minor calyces. So very rarely do we see a stone in the renal pelvis. I'm not saying never, because it does happen, but most of the time our stones are up in here when we have to go in and get out kidney stones. Sometimes they actually make their way down into the ureter and they get blocked down here in the ureter. When urine cannot drain from the ureter, we get what's called hydronephrosis. And basically the urine backs up through these calyces into the kidney and causes the kidney to swell due to an abundance of fluid. All right, let's look at our nephrons. Our nephrons, we start with the afferent arteriole. We go through the glomerulus, through the efferent arteriole, and Bowman's capsules right here at the glomerulus. Efferent arteriole, we go through the distal proximal convoluted tubules here. So this whole complex here is the proximal convoluted tubules. Down the loop of Henle, so descending loop of Henle, descending limb of the loop of Henle. So this is still part of the convoluted tubules. It kind of gradually forms into the loop of Henle. Loop of Henle, we have descending, we have ascending loop of Henle. We start into the distal convoluted tubules, going up this way, and eventually into our collecting tubule, which will drain into our minor calyces. All right, so what are we doing a nephrectomy for? Why would we want to do this? The most common reason for this is renal cancer. However, renal cancer doesn't automatically mean that you're losing an entire kidney. A lot of times the part of the cancer is in a part of the kidney that we can just take partial, do a partial nephrectomy and just take part of the kidney, so that we still leave our patient with lots of kidney function in the kidney that had the cancer in it. Hydronephrosis is kind of a big broad term for any disease pathology that is creating backup of fluid into the kidney. So there's several different etiologies for this. We talked about stones being one. Kidney disease is another one. Renal cancers obviously can cause hydronephrosis. There's a whole bunch of things that can cause hydronephrosis. Depending on how bad it gets, most of our patients will come in on dialysis. If dialysis isn't doing its job, we can put a nephrostomy tube in, which means that we're actually going to insert a tube into the kidney and let it drain to the outside of the body. So it will be like a bag that the patient holds that will have the nephrostomy tube in it, where they have urine coming, instead of a catheter coming from their bladder and outside, it will be a tube coming from inside their kidney to the outside. Sometimes when these patients have hydronephrosis to the point that they need a nephrectomy, then we are going to make sure that they come to the OR with their nephrostomy tube already in place. And we will remove the nephrostomy tube when we do the nephrectomy. Living donors. We do nephrectomy for living donors to be able to do kidney transplants for a recipient. Kidney transplants are the #1 performed transplant in the United States, because we can take living donor tissue and transplant it into somebody who needs it. When we are doing living donor transplants, we need to leave as much of the blood vessel and ureter attached to the kidney as possible. Remember that when we do a transplant, that the recipient patient will have 3 kidneys at the end of the procedure. We do not remove a kidney to add a new kidney. We actually leave that diseased kidney there because it may be giving some kidney function to our patient, just not enough for them to sustain life. easily without having a transplant. And then, of course, last but not least, we have trauma. The kidneys actually have the ability to heal themselves without blood supply. So if the trauma is not too severe, we can actually just allow our kidneys to heal on their own, and they will create their own blood supply. They'll fix tissue, all that stuff. But if the trauma is too severe, we have lots of bleeding, those kinds of things, then we're going to have to do a nephrectomy on our patient, which we never like to do. But just know if we have to do a nephrectomy, there will usually be lots of bleeding. So we want to make sure our patient is typed and matched, and that we have blood products on standby because we may need them due to those large vessels that the kidney has. So here are some pictures of some renal carcinoma. You can see the giant tumor here, and the tumor is actually kind of spread into the calyces of this kidney. So you can, this is a great picture because you can actually see the differentiation between the normal kidney tissue and the renal cell carcinoma. Hydronephrosis, we talked about, it can have several different etiologies, and one of the etiologies it can have is polycystic kidney disease. Yes, these are kidneys. They do look like livers, but these are kidneys. This patient has had a kidney transplant. Both kidneys had to be removed because they had so many large cysts on them. And so now the patient hopefully will be pain-free with their new kidneys, and will be able to help our patient along. Living donors. So we talked about having 3 kidneys. This is what this looks like, is that the donor kidney is implanted down here in the bottom right quadrant of the patient. And so we have whatever ureter we can salvage from the kidney right into the bladder. We can put the blood supply into the iliacs here inside the peritoneal cavity. So we still have the patient's original kidneys and their new kidney when we do a kidney transplant. Trauma, we talked about how the kidney can function and repair itself. So we are talking about this basement membrane here and the epithelial cells that line the basement membrane of the kidney. And what this allows the kidney to do is that it allows cells to crawl along this basement membrane and to build more cells along the basement membrane, thus allowing the cells to differentiate into different kidney tissue. This can become a problem, though, and cause hydronephrosis if things create constant inflammation in this area. So things such as diabetes create a constant state of inflammation here, and so you can actually have the kidney thinking that it needs repair when it doesn't. And so it will crawl along, the cells will crawl along this basement membrane thinking they need to repair this area and start making more and more cells across this basement membrane. This in turn thickens this basement membrane right here. And then it occludes the small blood vessels and things that are trying to come up through this basement membrane. So kind of a cool way to heal ourselves, but also can be a detriment in people with autoimmune diseases. I hope this helps with the anatomy and pathophysiology. You all have a great day, and I will talk to you soon.